I'm Dr. Alison Conlin. I work at the Providence Cancer Institute in Portland, Oregon. I'm joined today by
Dr. Heather McArthur. I'm the clinical director of the breast cancer program at UT Southwestern in Dallas, Texas.
Well, hello again.
Hi, Allie. We go way back.
Way back. You were fellows together.
Which feels like only a minute ago, but it might be a little bit more than that.
We both have teenagers now.
I think we might.
And we did not then.
So we were at Sloan Kettering in New York together, where we did our fellowship. I came there as an advanced clinical research fellow as a result of a grant from the Canadian government that allowed for further research training.
God bless the Canadians. Right. I'm so happy.
Which was just such an invaluable experience. It really was such a great time to be treating cancer, and there was so much creativity in our environment at that time. I'm not sure if we both appreciated, I should speak for myself, but I'm not sure I appreciated how special that era was.
Yeah, we learned a lot.
We learned a lot, and you could go to anybody's lab meetings, and you could come up with clinical trial ideas that were really outside of the box and get support. So that was a very special time in my life.
Well, good.
All the richer for meeting you.
And here we are today to talk about clinical data and early breast cancer.
Absolutely.
Yeah. So we're talking today about DB11.
We are.
Okay. So DB11 was a neoadjuvant study. Mm-hmm. Tell me a little bit about the design of the study.
So there were 3 arms in the study. Patients were randomized to receive one of these novel antibody drug conjugates. I mean, I guess not that novel anymore, but these drugs have moved very quickly from the metastatic into the curative-intent setting. Trastuzumab, Deruxtecan is the drug here. So it was a study that enrolled patients with HER2 positive early stage breast cancer.
High risk.
Very high risk. Very high risk. And randomized them to receive Trastuzumab Deruxtecan for 8 cycles versus Trastuzumab Deruxtecan for 4 cycles, followed by taxane with Trastuzumab and pertuzumab. So can you swap out the anthracycline component of some conventional therapies? And we just both spent time at Sloan Kettering. So we come from the house where dose-dense ACTHP was built. So can you eliminate the anthracycline by giving one of these novel agents? And then the third arm was dose-dense ACTHP.
Right. And so speaking about that high-risk group, they defined high risk as either T3 or node positive. So pretty high-risk group.
This is an extreme high-risk group. And when you look at all the successes that we've had in recent years, certainly in North America and in other parts of the world, we are identifying smaller tumors, improvements in mammography, improvements in patient education. So this is an unusual, I have to admit, or a minority population that I would see in my clinic.
Right. So would you think about an anthracycline-based regimen if you were thinking about this high-risk group?
I would for that high-risk group, especially if they were young, but nodal involvement, large tumor. Yes, historically, I have been giving anthracycline as it was prescribed in the control arm of DB11.
So in this study, they did not, they did report out the T-DXd, but they stopped enrolling early to the T-DXd,
which was kind of surprising, right? I think a lot of us thought that the T-DXd alone arm would be a success story. So I was a little surprised that didn't work out. But certainly the T-DXd, taxane, trastuzumab, pertuzumab combination certainly outperformed conventional standard of care therapy.
Right. Overall, the PCR rates of the T-DXd followed by THP was 11% higher than the anthracycline followed by
TB11, 11%.
TB11, 11%. Of course, seeing more benefit in the estrogen-negative group, up to 16% difference.
But that's normal. That's what we see in every trial, right? That we have much higher PCR rates in our ER-negative group than we do in our hormone receptor-positive group.
So a meaningful difference.
a meaningful difference, but it comes at a cost. I mean, financial toxicity, but also, of course, side effect profile. And as we know from our experience in the metastatic setting, trastuzumab deruxtecan specifically has been associated with significant rates of interstitial lung disease, low but clinically important rates. It requires a different level of monitoring and management. So physicians and patients need to be comfortable with in my mind, the increased intensity of follow-up, which isn't really what we would do normally. We don't normally do serial CT scans.
Sure. And in this study, they did a CT at 6 weeks, I believe. And so that would be something that would be extra. But interestingly, the interstitial lung disease rates were similar in both arms, maybe because it is only 4 doses of T-DXd. So
to my recollection, there was 1 fatality in each arm. And the fatality in the trastuzumab deruxtecan arm, I believe, was ascribed to interstitial lung disease. But again, ACTHP comes at a cost too, and there was a fatality in that arm that was ascribed to therapy too.
Correct. The nausea rates fairly similar, which again, an anthracycline. So I do feel like substituting out T-DXd for an anthracycline, they're both pretty toxic drugs. I think the real question lies, in is there a space or a place for, less intensive therapy? What do you think about switching it up and doing a taxane HP first as a lead-in? Do you have any thoughts about that?
Well, it would be purely speculation because I don't have any data to support any hypotheses there. I do think that just to your last point, I do think that the preemptive toxicity management is incredibly important. So it's not just ILD, but the nausea and vomiting can be real. So I inherited someone from the DB01 trial who was on trastuzumab deruxtecan for over 7 years for metastatic disease. Every time that she came in, we would talk about whether we should switch her to just trastuzumab alone or trastuzumab and pertuzumab. And then we always thought, well, if it's not broke, don't fix it.
I understand that.
Because she had no nausea. It was incredible. She had no side effects whatsoever. And then I had another patient who, after the second dose, again for metastatic disease, said, I don't care if this is the best drug on planet Earth. The nausea and vomiting for her was so terrible, she wouldn't consider continuing on.
Sure.
And that was despite 4-drug prophylaxis. So that preemptive prophylaxis is really important. Fortunately, most patients fall in the middle of those two. Those are 2 very extreme examples, but that building in that prophylactic regimen is so critical.
We've learned that over time with anthracyclines.
Right.
So perhaps in this neoadjuvant setting, we're going to need to think about that similarly, even with T-DXd.
Absolutely. And this is a treatment-naive group, right? Yeah. So they haven't had exposure to any of the side effects of any of our therapies to date. And so
they don't know how to use any of the drugs yet, any of even the supportive drugs.
Correct. Yeah. And so education is really important.
So coming back to the PCR, is that a meaningful enough endpoint to change care? Of course, the event-free survival is not, mature enough to know what strategies
the best. I think the FDA would say no. So I think it is, and we've seen this in the triple-negative setting with immune therapy, that the health authorities want to see the translation of PCR benefits into event-free survival benefits. And they've shown through their own cortisol meta-analysis and other similar studies with thousands and thousands of patients that PCR is very highly correlated with event-free survival. But at the present time, drugs are not being approved based on PCR alone. So I do think we need to see that data.
Okay. When you have a patient that you're giving neoadjuvant chemotherapy to, how are you using their PCR rates? Are you using RCB scoring? How are you using that?
Our pathologists, after, again, immune therapy in the triple-negative setting where the maximum benefit was observed in those patients who had RCB2, in response to that data, our pathologists did start scoring RCB in their pathology reports as part of a standard of care for all of our patients. It's a great tool. Of course, we don't know up front when we're making these decisions who's going to have a residual cancer burden and who won't. So we definitely need some biomarkers to better predict responses. But we don't have those today. So it really only makes a difference for me in terms of adjuvant systemic therapy decisions. So if a patient had a 5-centimeter tumor to start out with nodal involvement, and then has 1 millimeter of residual disease, I might think about that patient very differently than if they had 4 centimeters of residual disease and node positive disease. So I think these are becoming increasingly nuanced discussions. I actually had a patient the other day who I couldn't believe it. RCB, she was RCB2, but had 16 lymph nodes involved, but her primary tumor had completely responded. And so primary tumor size is actually a big part of the RCB score. So it was shocking to me that someone with 16 positive lymph nodes could have an RCB score of only 2. I would have expected.
Yes, I do feel like residual in lymph nodes is a high-risk situation, especially that many.
Yeah. So it's a good tool, but it's not a perfect tool. And again, because we don't have any predictors of RCB, I don't think having that insight has changed my practice as of yet. But information is power, and the more information we can get, I think the better decisions that we make downstream.
Thinking about this trial in general, how do you think it will get adopted in the community? How do you think our clinicians out there will would be an easy way to summarize it for people out there?
Well, we could summarize it by saying that Trastuzumab Deruxtecan in lieu of an anthracycline component together with taxane Trastuzumab Pertuzumab significantly improved pathologic complete responses. Event-free survival data is still forthcoming. So I do, again, think we need that data. And then I don't think you can talk about Destiny Breast 11 without talking about Destiny Breast 5, because we have more than one option now in the curative-intent setting. Once those therapies are approved in the curative-intent setting. So one of the challenges, I think, for us as a community is, should everybody get Trastuzumab Deruxtecan up front? Or can we limit use to those patients who are very high risk, who have residual disease? And the majority of patients, if you look at the COMPASS study, for example, with taxane Trastuzumab Pertuzumab only, more than 50% of patients had a pathologic complete response. So can we pare down neoadjuvant therapy and save these novel therapies for those patients who really are at high risk of recurrence, those with residual disease?
On the flip side, if you're a very high-risk patient, because we're talking about patients that are node positive or T3, and the vast majority of patients in this study were actually node positive, 88 or 90%. Would you want to get 4 cycles of your most active agent, limited to 4 cycles, not a lot of ILD with that, and then have such a high PCR rate and not need to sort of salvage anything in a post-neoadjuvant situation? I think that's the counter argument to that.
Yeah, no, and I agree with that. And I think that's where the event-free survival data is desperately needed, because if the magnitude of that PCR benefit really translates into a similar event-free survival, so a similar improvement in cure rates, then yes, I think that does become a more nuanced conversation. And yes, you would want to put your best foot forward for your highest risk patients. But at least in my practice, most of my patients with HER2 positive disease don't meet those high risk criteria. And so we're in an interesting paradigm where we're trying to tailor our treatment recommendations, escalate or increase treatment for patients who are at the highest risk, but also trying to pare down treatment to minimize toxicity for those patients who may be lower risk. And that's where we're really struggling.
So what about in the US where we know there's a lot of TCHP use? So, maybe not where we trained, but now maybe where we are. I live on the West Coast. So
remember, I lived in Los Angeles for 5 years, so I had that West Coast.
So, a lot of use of TCHP. How will we kind of grapple with this data with that? Do you think there's any short answer for that? There probably isn't. There's no head-to-head. This isn't the question that was asked.
Well, but I mean, let me throw that back and say NeoCarp, right? A platinum-free regimen performed exactly the same as TCHP, which begs the question,
what is that platinum doing?
Exactly, if anything. So we participated in the COMPASS trial. Again, that was taxane, trastuzumab, pertuzumab, high pathologic complete response rates. And I think that's probably enough treatment for a lot of our patients.
I agree. So that segues us into patients that are maybe that we find ourselves, we learn about at surgery, post-neoadjuvant, that they have residual disease. So let's talk about DB05.
Okay.
So in DB05, again, this was a high-risk group of patients. These were people you thought were inoperable up front. They had T4 lesions, they had N2 or N3 lesions, and of course HER2 overexpressing, or they were node positive after you gave them, everyone got a taxane after a taxane trastuzumab-based therapy. So how are you currently kind of treating those patients right now?
Well, in the absence of a health authority approval for trastuzumab deruxtecan, the standard of care is TDM1 per the Catherine study, and I think that's been our standard of care for a long time for patients with residual disease, no matter what their clinical features were up front. So that has been our standard of care, but I'm excited to be able to offer 14 cycles of trastuzumab deruxtecan to those patients instead, given how incredible the Destiny Breast 5 data looked.
So Destiny Breast 5 had a hazard ratio of 0.47, I think. It reminds me of when Catherine came out. We were so excited when Catherine came out, partly because that was a very novel concept at the time, but also because these high-risk patients, we want to be able to offer something different. So 14 cycles of trastuzumab deruxtecan versus 14 cycles of TDM1 in this post-neoadjuvant with an improvement already in invasive disease-free survival.
Right. And I hate the term game changer, but I really think that that study really is a game changer in my mind. And that's the drug I want to get access to for those high-risk patients. And I think the struggle, as we've already alluded to, is around who to give these amazing novel generation antibody drug conjugates to and when. So I would be very comfortable giving trastuzumab deruxtecan to patients with residual disease, especially those who are young and otherwise high risk, and then we'll perseverate over what defines high risk, of course, because I might think that a 25-year-old patient with node-negative disease but a sizable tumor is high risk for a variety of reasons. But I think accessing, I can wrap my head around accessing that novel strategy in the adjuvant setting a little bit more easily than I can in the neoadjuvant setting. Also, I appreciate your comments about
No, I think the flip side of it is to treat with maybe less toxicity, maybe a COMPASS HER2 regimen, get as many as you can PCR rates, and then know the biology of the people who need adjuvant therapy, and then give your best agent to the people whose biology showed you they need it.
Exactly, and that's where I'm at. And then we can further complicate the conversation by extrapolating from patina, and we're going to see HER2 CLIMB-05. Should we be throwing in CDK4/6 inhibitors too in that population?
Or oral TKI.
Or an oral TKI, exactly. So it's great that we have had such tremendous innovation. And I remember my first ASCO meeting was the meeting where they presented the 2 adjuvant trastuzumab studies. And I remember looking around the room and people were, crying. Hazard ratios of about 0.5. People were crying, and I thought, oh my gosh, these breast cancer meetings are so emotional. Not realizing how hugely impactful that data was in that moment. And now a few years later, to see even further innovation with these incredible hazard ratios. I mean, it's really incredible.
I agree. I often tell patients that the disease that has changed the most in my 18-year career has been HER2 positive cancer. We have made such incredible strides.
And I would say the patient population where I might be more inclined to give trastuzumab deruxtecan in the neoadjuvant setting might be that ER negative population where you really do see such an impressive complete response, and we don't have hormone therapy on the back end to offer them. So you really get that sort of that one shot at achieving cure. So I think that might be the subset of patients.
Right. It is always hard to know in the hormone positive how much the hormone blockade part is going to contribute to their cure, what's driving their tumor, until we have better biomarkers that might tell us right up front what's better by driving a tumor.
We need those.
How do you talk to patients about achieving a PCR or not achieving a PCR? In other words, we get to know our patients while we're doing neoadjuvant therapy. They go and have the surgery. We're real excited to see them, to see what happens. How do you put this into context in terms of their risks, in terms of what their next steps might be?
I really try to do the 10,000-foot view at the initial consultation. So I do, and I make drawings. If we achieve a complete response, and what does a complete response mean, then we're going to go down path X. If we don't achieve a complete response, we can still get to a good place, but we have to do something different. And so I really do try and map things out for patients up front, because in my experience, patients don't really love a pivot based on new information. So I do have the luxury of spending a lot of time with my patients at the onset, so I can kind of give them the whole overview of the different ways in which this could play out.
I think by the time patients get to that surgery point, you've seen them through their neoadjuvant therapy. They're kind of expecting, you can prepare them that we're expecting to get, I don't want to call it an answer, because it is an outcome for them that is a cure. I really try to emphasize to my patient that the surgery is the cure, and everything after that is extra therapy to make sure that cure rate is maintained or stays.
I agree. And those follow-up appointments are great opportunities to remind them what you talked to them about up front, because they only hear 20 to 30% of what you tell them in the initial consultation. It's also why I like to map things out in writing, so they have something to take home with them, to review with their family, to discuss, to remind themselves of the conversation. But then each of those subsequent appointments is another opportunity to remind them of where we're going and the decisions that we'll make down the road, because people usually need to hear things more than once. I know I do.
Yeah. Do you think talking about improvements in invasive disease-free survival, is that an easy thing to talk about with patients? Or
it's not language that I would use with a patient. We talk about the correlation of pathologic complete response if it's a neoadjuvant situation, which most of them are, and the correlation with curability of disease. That's usually the kind of language that I use, and underscoring for people, because again, they're coming in when they're their most frightened, right? It's a really tough diagnosis, and the not knowing what to expect. People always expect the worst. So I think to give them the opportunity up front to tell them that everything that we're doing is with curative intent. That is our goal. That's what we're working toward. And there are many different ways to achieve a cure. But everybody, all the disciplines, the surgeon, plus or minus the rad-onc, we're all working together to try and achieve that cure for you. And so that would be the kind of language that I would use in a consultation.
in this particular study, in DB05, it looked like there were about almost 75% of patients that could finish the 14 cycles of TDM1, a little bit lower, but still in the 70% range that finished the 14 cycles of T-DXd. Do you feel like that's how it works out in the real world?
I don't know. I feel like we have a sense pretty early on if people are going to have toxicity issues. So certainly the nausea can happen immediately, as we just discussed. The ILD risk is cumulative over the first 12 months, so you have to be hypervigilant about that.
There were 2 grade 5 ILD events in DB05. So
In DB05 and in DB11, there was 1 in each arm as well. So you really do have to be very vigilant. You really do have to make the investment of patient education so that they're reporting and communicating with you about any potential side effect issues. I have a patient right now who I'm treating with TDM1, and we've done 12 cycles and there are issues, and we're going to call it a day.
Yeah.
No one's ever going to, and we have enough data from the curative intent setting with shorter duration of trastuzumab. It's very arbitrary how these decisions about duration are made. So I think it really depends on the patient and depends on their specific experience. I will always try to complete the course of treatment that was offered and intended on the clinical trials, but sometimes you can't get there.
How do you feel about ILD monitoring in an adjuvant setting? In this trial, they looked at 6 weeks, and then I believe it was maybe every 12 weeks. So it's a longer 14 cycles. It's going to be a little bit of ILD monitoring.
Yeah, I think that's a lot. And that's why I'm sort of perseverating about the neoadjuvant versus the adjuvant space. And in the neoadjuvant space, it's only a couple extra scans, so it's not as onerous in terms of monitoring as the adjuvant space potentially. My practice, all of the recent DB studies have had monitoring every 6 weeks up front. I don't think that's realistic in the real world. So I typically, at least in the metastatic setting, I do them every 9 weeks because my standard of care practice has been to do them scans in general every 12 weeks. On the DB studies, they did them every 6. So I feel like I'm splitting the difference.
Yeah.
And patients are accepting of that in the metastatic setting. Time will tell whether they will also be accepting of that in the...
I mean, I think on one sense, it's a curative population. You really want to pick this up. It is 14 cycles is long, but it's relatively limited. You know, if you map it out, 5 CT scans, I mean, it's not the most, but it is a consideration that's different from what our normal practice is.
We do not want people to die of curative intent therapy.
Absolutely.
So I agree. You have to be incredibly vigilant. And fortunately, we have this experience in the metastatic setting. So I think people are a lot more comfortable than maybe they were a couple of years ago.
Yeah. So in this study, patients were allowed to have concurrent or sequential radiation. Of course, many of these high-risk patients will need adjuvant radiation. It seemed like that was safe. Do you feel like that will be adopted to?
That was my impression, that it was safe. And I think that we've adopted that in other settings. There's always concern, especially since there's been data from the brain met setting around co-administration of antibody drug conjugate together with radiation. And in that case, it was radiation necrosis. That was the concern. So I think that people have been concerned about co-administration, but this data from DB05, I think, was very reassuring.
Yeah, I think this allows us to do what we want to do as clinicians with our high-risk patients.
So we could argue, do you need to do that? Do you need to start your antibody drug conjugate while administering radiation? Is that
depends on
going to
what
add
kind of
value?
surgery they had. You know, if they have to expand or something from plastic surgery. So.
But I thought that was very reassuring overall.
Yeah. What about folks that are concerned about using T-DXd now in the more curative setting and then having recurrences later and reintroducing T-DXd? Is there anything that makes you
That's
nervous?
such a good question. I mean, we need to do that work now. I think we can anticipate that there will be 1, maybe 2 health authority approvals of Trastuzumab Deruxtecan in the curative intent space. So what are we going to do with patients? And we have faced this in the triple negative space too, right? With immune therapy, what do you do when someone recurs after Keynote-522? We're going to be in the exact same position because as of right now, T-DXd is our first line approach for many of our patients. So I think we need to do the work of doing the studies to inform best practice in that population. I think it's reasonable to extrapolate from other data sets, and we've done this successfully in the past. If there's enough disease-free interval from a prior cytotoxic that you can successfully re-challenge, what is that interval? Is it 6 months? Is it 12 months? I don't know.
Yeah.
I don't know. And then with trastuzumab deruxtecan, with pertuzumab, like, is that the right approach for people who are at least 6 months out from their recurrent? I don't know. It's hand waving and speculation. I really think that we need to do those trials.
Agree. Also, I like to keep in mind, I don't ever want to feel like I'm saving something for a worse situation later. I really still think that if we can cure more people up front, maybe we won't have as much of that problem. It's true. There are going to be people who still recur. We're still going to have to do these trials to understand. But we are seeing now in first-line HER2 positive trials and other HER2 positive trials, 70% de novo patients, because we're not hopefully seeing as many patients recur after all of our good upfront therapy.
Right. And I think our approach will vary depending on things like hormone receptor status. I mean, the patina data, THP with maintenance, CDK and hormone therapy for hormone receptor positive disease, that's impressive data, right? So you have that option. I think the more challenging space is going to be for those patients who recur with ER negative disease, where maybe the options are a little bit different, not limited, but different.
Yeah.
I think that is going to be a big challenge.
What do you see the biggest challenges with adopting these approaches overall?
I think the biggest challenges could be around the time, I think, that's required to really adequately educate patients to ensure that they're vigilant about any symptoms that might hint at interstitial lung disease. And, I work in an academic center. I have a little bit more protected time with my patients where I can make a commitment to them in that regard. I also have a patient-facing clinical pharmacist who also does a lot of education with patients. And then in the metastatic setting, I've struggled, with cold and flu season and all that non-specific.
It's so hard.
It's so hard. And the symptoms that are kind of mild, and you're like, do I need to worry about this or not worry about this? And then they get imaging and they're, scattered ground glass opacities, and they're non-specific, and you have to make big decisions.
So adjudicating any new pulmonary symptoms, maybe having some partnership, even in the community with your pulmonology group.
I think it would be a great investment.
Yeah. Imaging. So thinking about your high-risk patients, you have potentially, if all is approved as it could be, you have very high-risk patients who potentially can substitute 4 cycles of T-DXd instead of an anthracycline and follow it with taxane HP. Or you can have patients who were high-risk upfront or remain high-risk because of their node positivity after neoadjuvant therapy. And now you potentially could switch them to something better for adjuvant.
And I think, like with all the other decisions that we make together with patients, it very much reflects the patient sitting right in front of you. So an 80-year-old with node-positive disease, I probably would treat differently than a 25-year-old with node-positive disease.
Yeah.
An 80-year-old with COPD, I'm going to treat differently than a healthy 25-year-old. So I think these are becoming more nuanced conversations, and are really being tailored to individual patients and their tumors.
Balancing toxicity, efficacy, all the
100%.
options that you have available for your patients.
Absolutely.
Great. Thank you.
You're welcome.